Well, welcome everyone. Yeah, it's wonderful to be here at the Center for Global Public Health. And by the way, my name's Jeff Chow, for those of you that don't know me. Collaborate for Africa actually has its roots in the life science industries. I guess I didn't tell you that even, did I? Collaborate for Africa really started in 2009 when I met Dr. Basil Burke, PhD, at a B2DG bio-to-device group meeting. Basil is a biotech expert, and he was co-president. He's co-president of an organization called Kusoma International, which focuses on education in Kenya. So Basil asked what I do, and I said, well, I'm a financial advisor at Morgan Stanley. I work with individuals and families to manage their wealth, and I work with nonprofits on donor strategies. And Basil said, well, I have a nonprofit. Would you help us? Well, along with fundraising, Kusoma had some other structural issues. They were struggling with their 501c3 status. And as I found that out, I asked a snide comment. I made a snide comment. I say, if you have a great answer, you can make snide comments. And my comment to him is, why do you need it? And of course, they looked at me like I was crazy. And I said, no. I'm on the advisory board of One World Children's Fund. And if One World Children's Fund will accept you as a champion, they'll be your fiscal sponsor. People donate to One World Children's Fund, get a tax-deductible donation, and One World Children's Fund stated pass-through rate is 100%. It's their stated pass-through rate. Their effective pass-through rate is greater than 100%. Yeah. I like that expression. Yes, so for the money they've raised for their project, One World Children's Fund has actually delivered more money than they've raised. But I started thinking, what about other people doing work in Africa? Might they benefit from collaborating? So in November 2009, we held our first meeting, and Collaborate for Africa was born. So today, less than 2 years into this, we have about 400 members. It's grown amazingly, at an amazing rate. We typically host monthly meetings in San Francisco and at Santa Clara University. Of course, this symposium is an example of the type of effort that has come out of our C4A collaborations. To give you an idea of some other things we're seeing, next Saturday, Therese Helm, who's right here, and Dr. Wendy Leonard, who just walked into the room, are going to be at Roger Reynolds Nursery in Menlo Park from 1 to 4 p.m. And Therese will be selling her jewelry to support widow villages in Kenya, and Wendy will be selling baskets to support HIV/AIDS-related issues in Rwanda. Also that night, then, at Kepler's bookstore, also in Menlo Park, there'll be a showing of the film called Angels in the Dust, based in South Africa, HIV/AIDS related. And Wendy will be a featured speaker to talk about the work she's doing, again, HIV/AIDS related work she's doing in Rwanda, and answering questions about the AIDS situation in Africa. Other examples, Linda Kinney, who couldn't be here today, came to a Collaborate for Africa meeting in San Francisco, and at that meeting, Dr. Jan Gurley, MD, was talking about all the things that can go wrong medically when you travel. I think you were there, Gloria, right? And about an hour into the session, as Jan's describing all these horrible things that can go wrong with you medically and what you should do, somebody turned to Linda and said, well, do you still want to be part of our group? Linda has continued to be part of our group, a very active part of our group, and we didn't discourage her. She's still planning her first trip to Africa in early 2012. She's been consulting and will be traveling part of the time with Bernadette Frager, who I didn't see Bernadette come in yet, who's an RN, She's going to visit, we think she's going to visit Teresa's projects up in Kenya. And then I think she's going to end her trip with some time back in South Africa with contacts that Margie Slenoff from Teach with Africa is providing. So again, just this nice coordination of contacts. And of course, then we held a similar conference with the Children's Global Health Initiative at Corey Children's Hospital Research Institute in Oakland. Dr. Deborah Dean, who heads that Children's Global Health Initiative, is as a graduate of this program. And Dr. Desiree LeBeau is here. She was actually a speaker in Oakland, so she's continuing to be involved. We're thrilled for that. So those are the types of things that we're seeing out of this. If you're not a member of C4A and would like to be, just let me know. There's no fee. And I'd like to say, you know, on the 10th anniversary of 9/11, I mean, it's great being in a room of people who are really working to make the world a better place. So I'd like to end with a quote. It seems like a number of people have been connected with this quote, including Abraham Lincoln. Just to say, you know, the best way to predict the future is to create it. So with that, I'd like to turn the podium over to Dr. Eva Harris, Director. Here, are you ready? So Eva, it's...
Thank you very much. Thank you, Jeff. It's really wonderful. I actually physically met Jeff right now for the first time, but I think we spiritually met a long time ago. So what I'd like to do is welcome you in the name of the Center for Global Public Health here at UC Berkeley, and we're very excited to start this collaborative series of events with C4A. And what I'd like to do is to give you a little sense of the Center for Global Public Health, and then we're going to hear from our dean, who is not present physically, but has a video message, a little bit more of the spirituality there. But anyway, so he's here with us in spirit, and he'll be giving a little bit more of an introduction, and then I'm going to come back and tell you a little bit more specifically about what you're going to hear today, and then without further ado, we'll launch our program for the day. So the Center for Global Public Health was formed about 4 to 5 years ago, essentially to pull together all the really incredible international projects that are going on in our campus as well as throughout the Bay Area, and we've been branching out more and more to other partners. With the problem with forming the Center for Global Public Health was that we tried several times, but half of our faculty at the School of Public Health, which is only about 55, about 35 people work actively overseas. So you can imagine trying to actually get a quorum in the room at any one time is virtually impossible. And everyone gave up until I said, I'm going to give it one more try. And so we've been able to kind of pull together the work that people are doing all over the world, literally. I actually have a nice video, which I'm not going to show you, which is this Google Earth, and it kind of focuses in on all of these different projects until I'm actually nauseous because it keeps going around the world where all of our faculty are working. But instead, what we decided to do is actually just choose several who are working in Africa, because that's the theme today, and then you'll actually see kind of a smorgasbord of the different types of projects that are going on. And so one of the really important elements of the Center for Global Public Health is to allow an opportunity for students here to be able to go and firsthand experience the world and have these life-transforming experiences that for, just we have fellowships that allow about 8 students to go abroad every summer. And look for sponsors out in the community who can essentially sponsor a student to go and work with one of our faculty or our affiliated faculty. And for instance, we have one here, Sarah Ismail, and she's going to just mention a couple words. She was part of a framework program, which is actually a joint initiative between UC Berkeley and UC San Francisco. And just say a couple words.
I was fortunate to go to
Oh.
So I was fortunate to go to Zambia in summer 2010, part of the UC Berkeley UCSF framework program. And I went with faculty member Sue Ellen Miller, who teaches at Berkeley and is at part of the Bixby program at UCSF. So the work she was doing over there is with the non-pneumatic anti-shock garment, and it's one of the ways to reduce and prevent postpartum hemorrhage. We have other professors here working on postpartum hemorrhage as well, other ways of dealing with it, so it was really exciting.
Thank you, Sarah. So we have one program which is directed to students here to have the opportunity, but we have another which is essentially a faculty exchange, both of our faculty continuing their work abroad, but really importantly, an opportunity for faculty and health professionals in other countries to come and have certain training experiences here, as well as essentially health professionals at all levels who come to our laboratories and also our master's programs, et cetera. And we are going to hear today from Stella, who is in the back, and she will be telling us about her work in Kenya and the training that she's receiving as part of our Fogarty AIDS under the directorship of Dr. Art Reingold, who's actually the associate director for the CGPH. So you'll hear from her later on in this, program. The other thing that we're doing to kind of engage more with the community around Berkeley is starting to organize donor trips to our sites. And so we're actually excited to be preparing for our very first one, which is going to be in 2012, and that's going to be to Guatemala, to the site of Dr. Kirk Smith. And one of his big projects has been in reducing indoor air pollution using cook stoves and others. And actually, you'll hear about his project, and Nap Hosang. He's actually, Kirk is out of the country at the moment, but Nap Hosang has been very involved, and he's going to speak about essentially translation of this out into nonprofits and out into the field in Uganda and other places. And so if you were interested, you could actually have an opportunity to go and visit the sites in Guatemala where they've been working. Then we have another way that we're starting to branch out further in the community around here, which is we're in the process of forming what we're calling a board of directors, which is going to be people from the community who are interested in the work of the Center for Global Public Health. And there'll be essentially once a year a more formal meeting of the board, but then the members can have individual lunch meetings or others and engage more directly with particular projects of interest of the different faculty. So we're trying to spread beyond, as we call it, the ivory tower into the community, both here as well as what we know we do well abroad. And then the point really of the Center for Global Public Health is to bring together a truly interdisciplinary approach to research, and more importantly, the translation of that research out into communities. And that, I think, is one of the things that UC Berkeley and this Global Public Health does best. We have, when I mentioned these 35 countries, it's actually faculty, I should say, that are working in 25 countries, but they've been working there for about 30, 40 years, most of them, anywhere from 10 years on. So it's not this global health you might have heard of as this kind of trendy movement within the last 10 years, but in fact, people here have been working 30 some years and have developed really, really long-standing partnerships all over the world. And I think that is a really exciting part. And then the problem has been that everyone is so busy working these places that we haven't been able to nucleate here, and that is exactly what the CGPH has been able to do. And so we're really excited that one of the projects that we're most focusing on now is on slum health, and it's got a lot of different people in the audience are involved on many different levels. So we have infectious disease, chronic diseases, we have city planning, human rights, land rights, and as well as you'll hear from Malcolm Potts and Martha Campbell, who is here in the audience, who've been involved on the reproductive health side of it. So the idea is to take really urgent problems in health and in global health and be able to attack them from a truly multidisciplinary angle and to be able to nucleate that and facilitate that through the CGPH. So we're hoping that today you can get a sense of that kind of work by the different faculty who are participating. And with that, I'm going to close my remarks. And I want to first, though, thank the people who've been instrumental in putting this together. Of course, Jeff Chow, and thank you so much for allowing and enabling this to happen, and really incredible amount of work for the last several months, and especially recently by Miriam Rafiq, who is our coordinator of the Center for Global Public Health. Thank you, Miriam. And also, yes. And our wonderful interns, and I also want to mention Pat Hozell, who's been really involved, as well as Malcolm and Martha, who've been actually working to put the program together in addition to speaking in it. So with that, I will turn over to, I guess, our dean. Yes. So someone's going to deal with this. Not me.
Let's see, where is it? On behalf of our School of Public Health and our Center for Global Public Health, I want to welcome you today to today's event. And I know you're going to enjoy our speakers and the issues that we want to engage you with. I regret that I cannot be there. I'm traveling back from Institute of Medicine meetings on the East Coast, but hope to meet many of you personally in the future at future events. I want to especially thank today Jeff Chow and Collaborate for Africa for co-hosting this event with us. I want to also at the outset thank Miriam Rafiq and the staff for organizing the event today, and of course for our speakers as well that you'll hear from later today. The Center for Global Public Health here at Berkeley is part of the Berkeley Alliance for Global Health, which is really a partnership between our center, started about 4 or 5 years ago, along with the Center for Emerging and Neglected Diseases. And we have put these together to constitute the Berkeley Alliance for Global Health, which engages multiple entities here on the Berkeley campus addressing some of the challenges you're going to hear about today. These include molecular and cell biology, obviously our School of Public Health, but also our School of Engineering, our business school, our law school, and a number of other entities on campus. And we take a very multidisciplinary approach to addressing some of the challenges we face. I also want to indicate that the faculty you're going to hear from today in the center overall are working in over 30 countries, addressing some of these challenges that we face increasingly, ranging from uncontrolled population growth to the emerging and re-emerging infectious diseases, to the health impact of climate change, and a number of others. A recent issue of our school magazine, Berkeley Health, which you see here, features some of this work. And if I can just quote from one of the articles, because we'll be hearing from Malcolm Potts, Nadola Prada, and others today on a sustainable planet. And as we indicate here, that you're hearing a lot about some of these issues and the dire predictions that are going to happen around the year 2050, with the carbon emissions raising the planet's temperature by at least 2 degrees Celsius or more. The world population at that point in time could stand as high as 10 billion people in 40 years. That will place a huge strain on our dwindling resources. And some of the implications of that you will be engaged with today. But I also need to say that all of this work is being threatened today by the state budget cuts and the fact that our endowment is far less than that of our private competitors to address some of these problems. So if we look at our neighbor to the south, Stanford, just as one example, their endowment is 6 times that we have available here at Berkeley. The modest course support that this center has from the university, $100,000 only, will disappear after next year, and we will be unable to provide even minimal support that we have now to this center and its activities. And one of our biggest challenges, as you're going to hear about today, is bringing these initiatives to scale where they can have a wider impact on people and also the ability to sustain them over time. These are wonderful opportunities that we have to grasp. And to do this, quite simply, we are going to need your help. Eva Harris, director of our center, you will hear from Eva. We'll talk more about specific ways in which you can help. We seek your engagement as partners in our work, but we also want to know what's on your mind, what your concerns are, how you want to contribute, and how you want to make a difference, and how we can help you make that difference. And I just want to thank you for coming today. I really do hope I get a chance to meet each of you individually at future events and as we join you in this work together. Thank you for coming.
Okay, great. I don't know what to do here, but I suppose turning it off. I don't know. Closing it. There you go. Go away. Okay, so I am just going to really briefly tell you the outline of today, the program. And so we're going to first hear essentially a keynote speech from Dr. Malcolm Potts, who's going to be telling us about avoiding the next great global catastrophe, which is the crisis in the Sahel. And then we're going to follow that with a talk from Ndola Prada, who's going to be talking about low-cost solutions in the area of maternal and child health. And then we're going to have a break, which is really a quick bio break and like a stretching break because we want to go on with the program. And then we're going to kind of branch off. Those were kind of two related talks, and then we're going to go into this, what I call the smorgasbord of the different types of work that's going on. And I mentioned we're going to hear from Stella Njuguna about HIV research and care in Kenya. We're going to hear from Coco Auerswald, who I just saw a second ago, and there she is, who is a professor both at UC Berkeley and at UCSF, and she's going to be talking about her work with street youth in Kenya, as well, actually, as her work in San Francisco. And then we're going to also then move into the work of the STOVE project, which I mentioned that was going on in Guatemala, but we're going to hear about its extension into Uganda and Dr. Hosang is going to give us that talk. And then we have a surprise guest who we're so excited was able to move her schedule around, and that is Dr. Laura Stachel, and she's going to talk about her program, which is called We Care Solar, which is using solar power to improve maternal health outcomes around the world. And she's going to focus on her work in Africa. And so we're really, really happy that you're able to join us. But we want to continue, and Miriam's going to keep really strict time because what we want to make sure we don't do is move into our nice networking time afterwards. So after this ends around 4:05, we'll have about an hour with some refreshments that you can really interact with between yourselves as well as with us, who will all be around today. So thank you. And I'm actually doing the introductions. So now I'm back as the MC. So we've got Malcolm Potts coming up next, and we're very, very excited. So I have the formal bio is that Professor Potts is a Cambridge-trained obstetrician and reproductive health scientist who has made population, family planning, and women's health the focus of his work for the past 40 years, which I just realized here. He's actually been working in over 100 countries. Go figure. Wow, and published 11 books and over 200 scientific papers. At Berkeley, he's the Bixby Professor in Population and Family Planning, and he founded our Bixby Center for Population Health and Sustainability. And for 10 years, Dr. Potts was the first medical director of International Planned Parenthood Federation. And that's the formal part, but I know Malcolm from the impassioned speeches that he gives about his work and about women's rights and reproductive health rights worldwide. And now, as you'll hear, about how to avoid the impending disaster in the Sahel. And we're very excited to have him be our keynote speaker. Thank you, Malcolm.
Thank you very much for having me here. My talk takes off directly from our title, Addressing Tomorrow's Global Health Challenges in Africa Today. I'm going to begin with 10 minutes of doom and gloom, and then turn, I hope, to 20 minutes of solutions, and the role of this great university. I think if we could draw isobars around human suffering in the way that the weather forecaster does about high pressure, then I think the high pressure of human pain and suffering would be in the failed and failing states in the Sahel and across to Somalia, Yemen, and Afghanistan. Along the edge of the Sahara Desert, rapid population growth, global warming, poor governance, a hideous mistreatment of women are all combining in a perfect storm which could lead to unprecedented levels of starvation, escalating conflict, and massive waves of migration. I think the potential for human misery is colossal, and I think the need to act is very pressing. The scale of the problem I'm dealing with goes beyond the usual School of Public Health or even a university campus. I'm talking about building strategies with major geopolitical implications for the rest of the 21st century. Fortunately, I think UC Berkeley is very well placed to do this work. Our brains weren't evolved to deal with millions, let alone billions. We're easily numbed by numbers. Paul Slovic of Oregon took a sample of Americans. He told a story of an African child. He shows this child's picture, and he says that this child is hungry, and asked them what they would give. I couldn't change they said they would give an average of $2. It's supposed to be $2. Then he told the same story and said, by the way, there's 1 million other hungry children in Africa, and people gave less. Then he just gave the statistics, and they gave least. And I think it is difficult to deal with some of the problems that face us. My metric for a massive catastrophe is the Second World War. I was a child during that conflict, which killed 26 to 34 million people. In my professional life, I've had a ringside seat on what happens when we fail to act decisively as soon as a new problem arises. In the early 1980s, I was president and CEO of a large organization called Family Health International. I predicted that a new, lethal, sexually transmitted disease with a strange name of AIDS could kill a lot of people. Few listened. But I was able to gather together enough money, private money, to initiate the first sex worker education in Africa. This led to our winning of the first USAID contract to slow AIDS in Africa. It was too small, and it was too late. In the next 30 years, unless strong action is taken, I believe a catastrophe that's now unfolding in the Sahel could kill as many people. This is AIDS, and then there's 30 million people died of AIDS, and 34 million people still carry the virus. And then what's going to happen in the Sahel? I think it'll be at the same level, or might even be greater. So I want to share 3 messages. To spell out how rapid population growth in ecologically unstable areas is threatening tens of millions of people, to suggest how we could avert this mega disaster, and to argue why we must learn from AIDS and act boldly, decisively, and with urgency. The problems I see are simple and obvious. In the Sahel, the average age of marriage is low, sometimes as low as 14. Women average 6 to 7 children. The population is growing rapidly, and the food supply is diminishing. Overgrazing, soil erosion, cutting down trees for firewood are going to collide with climate change, which will make a serious problem into a catastrophe. The current population of Niger is 16 million. 16 million. It will reach 60 million in 2050. I think it's unlikely, to reach the 139 million predicted by some demographers for the year 2100, because I think death rates will rise before that. Burkina Faso is going to go from 16 to 50 million. Chad from 11 to 30. Mali will double from 15 to 35. Somalia from 10 to 20. The contemporary world can be divided into 3 very different parts demographically. 42% of the world has replacement level fertility. That's an average of 2 children or fewer. 40% average 4 children or fewer, and their birth rates, I think, are likely to continue to fall. They're countries like Kenya. 18% continue to have extremely high fertility, averaging 4 to 7 children. Until recently, the UN Population Prospects adopted the strange convention that most countries will drift by some magical process towards 2.05 children. There's absolutely no evidence base for this assumption. And earlier this year, the UN did revise its population estimates, accepting that birth rates in these high fertility countries will not reach replacement level anytime soon. The results are startling. Commentators like to talk about the median 10.1 billion projection for the end of the century, or even for the middle of the century. But the director of the UN Population Division explains that the median variant is no more likely than any other projection on this diagram. Whether we take the highest projections or the lowest projections, it's these high fertility countries that are going to, whether you're talking about here or here, that become the largest single population group at the end of the 21st century. In Arabic, Sahel means shore. It's this 2,000-mile-long strip of hot, dusty earth fringing in the southern border of the Sahara, from Senegal to Eritrea. It's an ecological definition, not a political boundary, but at least 50 million of the world's most forgotten people doggedly attempt to survive in very harsh conditions. From June to October, there's no rain, and temperatures can exceed 120 degrees Fahrenheit. Scientists studying lake deposits have shown that even before global warming, the region was subject to prolonged droughts every few tens of years. Climate change is making a bad situation worse. Droughts that used to occur every 10 years are now coming every 5. Global warming is almost entirely our problem. It's our lavish consumption in the north. But it's the poorest 2 billion people on this planet who are going to suffer most, and who incidentally only create 3% of the global greenhouse gases. Already, agricultural output cannot keep pace with population growth. The UN rarely uses very direct words, but here they say that the Sahel is heading for an environmental disaster, and feeding tens of millions of people is mission impossible. The minimal education system, the abysmal status of women, and then makes non-agricultural employment impossible. Currently in Niger, 1 in 1,000 girls finish a secondary school, and the schools that do exist are falling down. These are all a harbinger of worse things to come. The one thing worse than predicting a disaster and not being heard is to predict a disaster and then watch it unfold more rapidly than you expected. The day my wife and I, Martha Campbell, reviewed the proofs of a paper that's out there on Niger, the BBC and the UK press had the first really good coverage of the refugee camps in Kenya. Now there are, in the Dadaab refugee camp, which is built for 90,000 people, there are now 400,000 refugees. There's 1,500 more women and children arriving every day. And it's always the women and children who suffer most. Oops. And remember, if a malnourished child who doesn't die, there's a lifelong penalty of stunted growth and retarded brain development. So the worst drought in 60 years is hitting the Horn of Africa. 12 million people already hungry. On Tuesday of this week, the New York Times reported, and I quote, 750,000 people could die in the next 6 months unless efforts are scaled up. Now, I think this time probably the efforts will be scaled up. But what's going to happen 10 and 20 years down the road when the same thing happens on a much larger scale? The misery of refugee camps is going to be, people are going to be hungry, more and more people are going to migrate to the slums of Ouagadougou and Bamako and Kano, which are already very poor. There's going to be unemployed, malnourished people. There's going to be more conflict. In Darfur, 200,000 people have been slaughtered and tens of thousands of women have been raped over a fight for fertile land, and there'll be more Darfurs in the coming decade. Yesterday, one of our staff, Paige Bassano, left for, she's part of the Bixby Center for Population Health and Sustainability. She flew to Nigeria's capital, Abuja, and only 2 weeks ago, exactly where she's going, a suicide bomber from the Boko Haram fundamentalist group blew up the UN building. I'm sure you remember that. 18 people were killed, but 200 more people have died in additional fighting. As we think of what happened 10 years ago, it's sobering to see Al-Qaeda-like groups springing up in the Sahel. The Shabab faction in Somalia bans wearing bras or having gold teeth and flogs women who show their ankles. This kind of misinterpretation of religion arises because of rapid population growth, outruns the ability of even a competent government to educate or provide employment for ever-growing numbers of volatile young men with no future for themselves in sight. As populations triple or double, extremism in politics and religion is likely to increase. More and more attacks will occur within the countries and outside, some of them aimed at us. the 9/11 Commission concluded rapid population growth and unemployment are a sure prescription for social turbulence. This is not a graph of a high, low, and medium population projections. It's a unique presentation developed by Venture Strategies and the African Institute for Development Policy, showing the impact of the final year in which a country achieves a two-child family. So if Niger has a two-child family in 2060, they go from 16 million today to 18 million. If they don't achieve that till 2080, they go to an impossible 120 million. But enough doom and gloom. Let's look for reasons of hope. Oh, I know what I've done here, and I'm sorry. So, the first step is to recognize the nature and scale of the problem and to focus on outcomes, not processes, to show that to slow rapid population growth, we must make family planning easy to obtain and end child marriage. When I started working AIDS in the 1980s, there was a lot we didn't know about this disease. In the case of family planning, we have half a century of robust evidence of what works. Technical innovations attract donors like Gates, but to save millions of lives, we need to bring to scale technologies we've known about for decades. We must build human capital rather than physical infrastructure. We must meet the unmet need for family planning. Even failed states like Somalia have markets. We must knock down the non-evidence-based medical barriers to family planning. And we must recognize how much misinformation there is in this field. Consider this example. UNICEF and the Doctors Without Borders fail to include contraception in their work in refugee camps. But sex continues in refugee camps. Some of it's coercive. In 1975, I visited Phnom Penh during the siege. I asked to sleep away from the other side of the hotel from Pol Pot's rockets. And then sometime later, when Pol Pot fell, my Thai friend Michai Viravaidya had the good sense to offer contraceptives in Cambodian refugee camps. The use of contraception jumped from 0 to 52% in 1 month. Contraceptives should be easily available in Dadaab and the other refugee camps that are springing up in Africa, and they're not there. This is the kind of realism I'm appealing for. High fertility countries will not slow population growth until the average age of the first birth is raised. Judith Bruce and John Bogart's quoted here, calculated increasing the age of marriage by 5 years reduces population growth by 15 to 20%. A girl who has several children by the time she's 20 never has the opportunity to learn how to manage her fertility later in life. In Niger, the average age of marriage is under 16, and 1 in 5 women has 10 children or more. Across the globe, 25,000 underage girls are married every day. Most child brides never go to school, or they drop out when they marry. They are, compared to mature women, they're twice as likely to be beaten by their husbands and 5 times as likely to die in childbirth. Personally, I think child marriage is an unacceptable human rights abuse. Now, there are many things, easier things that we could do in Berkeley than striving to increase women's autonomy and slow population growth in the Sahel. But I'm getting older and I'm impatient. I believe we should go where the biggest problems are, not where the money is and not where the nicest countries happen to be. However compelling the evidence, the most difficult task in a democracy is to get politicians to take an interest in any event beyond the next election. Huge but slow-moving catastrophes may be the most difficult of all to bring to public attention, but it's these mega catastrophes taking decades to build that are ultimately the most important. I want to suggest that we assemble a Sahel strategy task force on the Berkeley campus. It should be composed of those experts best positioned to confront urgently the collision between demographic growth and climate change. To start with, we should include people in family planning, education, food security, water, governance, human rights. The task force would work closely with international partners. including the, I don't know why it does that. With international partners, including AFIDEP, the African Institute for Development and Population, and our own Bixby program with colleagues at the Ahmadu Bello University in northern Nigeria, which is the Population Reproductive Health Initiative. The task force will build evidence-based scenarios and big picture strategies on food, water, governance. And it will ask, what can be done in the short term to make family planning immediately available? And what can we do in the long term to raise the age of the first birth? Any good university can handle demography or technical information, but we have an outstanding record in human rights, and we need to ensure that all family planning is entirely voluntary and conducted in a human rights framework. We need to move forward to build networks and cross-disciplines. Exactly as Eva was saying, the primary goal of the UCB Center for Global Public Health is to build those networks. And I'd like to thank Eva and Miriam for putting this meeting together. The school and our campus are leaders in climate change. There are over 400 faculty engaged in work on energy, climate, and the environment. We're already leaders in a number of disciplines that would have to come together. John Holdren, who's the President Obama's Science and Technology Advisor, was at UC Berkeley for 20 years. We need to build links with experts on water. We have some initial links with French parliamentarians and French universities, and we will need to strengthen these. After 12 to 18 months, I see the task force transforming into the Sahel Monitoring and Policy Institute. The Institute's goals would be to create plausible, achievable, short and long-term outcomes based on accurate, validated, compelling data, data that's robust enough to command the attention of governments and intergovernmental donors. It's a university that can look at the evidence and take a long view. A university should not be numbed by numbers. Policymakers often want simple solutions. In contrast, a university can juggle complexity. Without exception, the high-fertility countries suffer from many interacting problems. Poor soils and unpredictable weather are outside our control. Colonial exploitation in the past cannot be undone. We don't know how to ameliorate corrupt government. Subsidies to American farmers depress African markets unfairly, but they're unlikely to change. We need a campaign to change the millennium-old traditions of patriarchy. The policies needed in the Sahel involve empowering communities and challenging the non-evidence-based medical traditions, which often prevent women getting family planning. As a physician, I'm pleased to be in the only school of public health in America that's not attached to a big medical school, because I think we have that vision and freedom to think about problems and take issues down to the community in low-resource settings. Now, population growth is only one among many factors, but I would suggest it's a critical one, and unless population growth is slowed, then all the other problems that we talk about become impossible to overcome. Also, making family planning available is a first essential step towards a woman's autonomy. To succeed, we must engage our colleagues in Africa. I will see that process beginning on day one. We've worked for 6 months with the Population and Reproductive Health Initiative for 6 years in Nigeria. And we have an outstanding partner in the African Institute for Development Policy, the foremost African group translating evidence-based information on population, voluntary family planning, and health for use by African governments. Eliminating forced marriage for young girls and raising the age of the first birth will be difficult, but our work in ABU in northern Nigeria is showing it is possible. One of the lessons I learned in AIDS was a reluctance to talk about the risks of multiple concurrent sexual partners in Africa because it was perceived to challenge cultural traditions. But societies may be nearer the tipping point in cultural change than we sometimes think. The work our Bixby Centre has been doing with Nigerian colleagues is a microcosm of the bigger effort I'm advocating. We are working in a Hausa-speaking, polygamous society where the average age of marriage is 14.5 years. It's close to the border with Niger and subject to the ecology of the Sahel. My co-investigator, Daniel Perlman, who's in the room, and our Nigerian colleagues are supporting girls and providing a small cash payment to keep girls in secondary schools. The parents ask for this money to go to the school, not into their pockets, even though keeping the daughters in school is a drain on their limited income. In the first year, the blue bars, which is the control, the second year was the first real year of the project, and the third year is the green bars. These are stunning results. For just over $30 a year, between 82 and 92% of girls are remaining in school. The total cost of reaching 50% of the adolescent girls in Niger with this type of work would be $15 million. That would be a genuine revolution that I think is achievable and affordable. This really is a light at the end of a very long, dark tunnel. So we need to develop plausible strategies and budgets to take pilot projects such as this one to a nationwide scale. We need careful random control trials to show cash transfers work. Eva Harris is doing great work in Latin America, and we want to learn from you. The goal of averting the catastrophe I have described requires a new vision. The World Bank and regional development banks and the traditional donors such as USAID and DFID need to continue to invest billions heavily in education and health. For example, they need to build more schools. But they need also to give much more priority to investing in girls and in voluntary family planning. The role of the Sahel Monitoring and Policy Institute, along with what I'm sure would be a very rapidly growing network of colleagues, would be to establish strategies reflecting this vision. I sincerely believe that Berkeley is better placed than anyone else to generate compelling evidence-based strategies on the need for action, what that action should look like, and what can go wrong. We can design and implement research needed to convince the World Bank and others to do the heavy lifting. We have the advantage of being the first in the field. No other institution or university is highlighting the collision between rapid population growth and global warming in the Sahel in an all-inclusive way, and then suggesting comprehensive solutions. The earlier any public health effort is made, the greater the long-term leverage. UC Berkeley has got an unrivaled reputation and record in making family planning available in tough situations, and Dr. Andola Prata, my colleague, will follow up in a moment. Andola took healthcare to rural populations in her own country, Angola, during the Civil War. A world in the second half of this century where the largest single block of the global population is poor and sometimes destitute, hungry and sometimes starving, uneducated, unemployed, and often radicalized, and where tens of millions of women are treated in loathsome ways, is indeed a big problem. But we're well positioned to tackle big problems. Big problems have to be tackled first in universities. Several $1 million invested now might well be one of the most leveraged things it's possible to do for the future of our fragile planet. But I also recognize that no philanthropist is going to donate to a lost cause. We need hope. And that's, in a way, our greatest strength. Berkeley has ingenious undergraduates, as in the Blum Center, stellar MPH students, and unrivaled doctoral students, some of whom are with me today. So let me end by circling back to my experience in AIDS. In 2010, international assistance for AIDS was $6.9 billion. In the mid-1980s, the first year of funding I received from the US government to slow HIV in Africa was about $12 million. Although my staff and I worked 24/7 trying to slow the pandemic that was to kill millions of people, In retrospect, we had made very little measurable difference. We had too few resources, and it was too late. Allowing for inflation, my $12 in the 1980s was equivalent to less than 1 day of current expenditure on AIDS. If we'd had 1 month of today's current expenditure in 1985, I believe we could have prevented AIDS killing as many people as died in World War II. I suggest that to avert a mega catastrophe in the Sahel, a case should be made and constructed that while investing in family planning and in the well-being of girls and young women will not of itself bring peace or development or feed people, not investing in family planning and in girls and young women makes survival unachievable. I learned watching AIDS that we must take action with greatest leverage. If you want to help these wonderful young women, then the time for action is now. Thank you.
Okay, well, I told you he was a compelling case and a compelling speaker, so let's go. I would like to follow this up. I guess because of the time, I think we'll probably go on and not do a question and answer session now, and we'll have that during a little bit in the break and then after in our networking session. But as you can see, we have a vision both from the compelling catastrophe which is unfolding as well as the solution and what can be done now. And we're going to be followed by Ndola Prada, who is going to speak about her work that is connected to this problem, but the work she's been doing on the ground in rural communities in bringing solutions to the maternal child health problem, especially the maternal mortality, and slowing that rate. And so I'd like to introduce Ndola, and she is a physician and a medical demographer from Angola. She's an associate professor in residence in the School of Public Health here at Berkeley, and she's also the scientific director at the Bixby Center, and she's the medical director of Venture Strategies for Health and Development and Venture Strategies Innovations, and you saw some of their data in the previous talk. Much of her work has been in many African and Asian countries, and it's been groundbreaking research designed to get governments to change their policies. So actually bringing services, but then being able to take evidence from that to be able to change policy at the governmental level. To empower communities to solve health and family planning problems. And I've been really lucky to have her speak in some of my classes, my courses, as well as to share the podium with her at other events. And she always blows me away with and I'm sure she will do that again today. So I'm really happy to welcome Ndola.
Good afternoon, everybody. Thank you so much, Eva. So, what I will follow in the next 10 minutes is to look at some of the solutions that I will propose to you that I've been actually trying to implement in some places with a great deal of success in many circumstances. It is important to note that in many resource-poor settings, there is a growing unmet need for contraception, and it is an astounding need. Couples who wish to have fewer children are not able to determine the size of their families and when they can have their children. So it is really, really important to fulfill their goal of this family, especially the poorest of the poor. The demographic health surveys find an average of 30% of sub-Saharan African countries, 30% of women in sub-Saharan Africa have an unmet need for modern contraception. What this means is that they either don't want to have any more children or that they want to delay the next pregnancy for at least 2 years. That percentage increases significantly because 19 of the 31 countries where this unmet need for family planning was measured, the unmet need is actually 49%. So what is important to realize as we listen to the importance of family planning today is that family planning is not telling women how many children they should have. It's on the contrary, it's giving them the information and the ability to have the number of children that they want when they want to have these children. It's also important to note the importance of family planning at the population level. It is unjust that women in the most poor countries of the world are dying simply because of the unmet need for contraception, and we still have this problem today. It is estimated that promotion of family planning in very high fertility countries, so those 18% of countries with the women having more than 4 children that Malcolm has presented, could prevent 32% of maternal deaths and nearly 10% of child deaths, even if we just focus on the benefits of family planning related to maternal and child health. That is tremendously important for these countries. Remember, these are countries where the greatest burden of disease takes place, the resource poor countries in sub-Saharan Africa. It is also the countries that has the lowest percentage of the healthcare force. So what we call the quick wins in saving lives, both women's lives and children's lives, are very, very important for low resources, and this is what family planning can bring. So I will propose to you today 4 steps to increase family planning. The first one is the importance of increasing knowledge about the safety of family planning methods. And I will go into a little bit of detail, giving you the bad side, but also the hope that exists. It is important to ensure that contraceptives are accessible and affordable to the poorest family. It's not just say, well, contraceptives are in the pharmacy. Who can buy them? How long does it take a woman to get to the pharmacy? Can she actually go to the pharmacy without the permission of her husband, for example? Or does she have the money to do it? Also important is to ensure that there's a supply of contraceptives, and to ensure that it is important that countries have a permanent line item budget. As part of maternal and child mortality reduction, it's important to have contraceptives right there, the same way that we have oral rehydration salts, immunization for children, antibiotics, all of that. Family planning methods can help the same way. It is also important to reduce barriers hindering access to family planning methods, and I will go into a little bit more detail to each one of them, but I promise Miriam I will be on time. It is important to increase the knowledge about the safety, and look at this graph for what is happening in sub-Saharan Africa. We have more women with unmet need for family planning than actually using contraception, and compare it to the Northern Africa, and that is the good news. It means that it can be done. So we can learn. This is an example from Northern Africa, but there are other examples also in Latin America and in Asia. It is important that the correct knowledge is well known in terms of the safety, in terms of the side effects, to deal with the misinformation that women have related to contraceptives that sometimes prevent them from using them correctly. So the next one is to ensure that contraceptives are accessible and affordable to families. Why is this important? We're talking about a sub-part of the world where 7 out of 10 of sub-Saharan Africans live on less than $2 a day. And 40% live on less than $1 a day. In the Sahel, as Malcolm has mentioned, extreme poverty is the rule rather than an exception. It is also important to know that 3 out of every 4 urban dwellers live in slums. So very, very poor. So you have to understand that the poor are very sensitive to price changes. So if you have 3/4 of the population that you can see from some of this data done here at UC Berkeley that will not be able to afford the full cost of contraceptives. That means that in order to achieve the benefits that we have, they need to be either subsidized or given free of charge. Because the smaller resources that families have for food and for education and for health of their children, they're not going to be used for family planning methods. And we just have to understand that. It is also important to ensure the supply of contraceptives. And I'm bringing here the example of Kenya, where what you see in this graph is that in the late 80s, a huge influx of funding, both internally from local government and externally from international agencies, with the recognition of the benefits of family planning. And then you see a contraceptive use going up, a fertility rate coming down. With that came also the benefits of a decline in child and infant mortality. And then in the late 90s, what happened? Change of government, no political will to continue this program, tremendous reduction of the international community in terms of funding for family planning. And this is what we see. I'm just bringing the example of Kenya, but there are even more drastic examples. A stall in fertility, no change in maternal mortality, even a decline in the sort of the gains that we had already achieved in child health indicators, with a slight increase in child mortality. So you take the pulse out of a family planning program, it stalls, and it has all of the devastating consequences to all of the health of the population. So very, very important to have that. Lastly, looking at the barriers that hinder family planning. The barriers, I'm bringing just a few of them related more to the legal and medical barriers. And it is important to dispel the myths of who can provide contraceptives and where they can be provided. Lots of unfounded rules, cannot get a contraceptive method if it's not married, cannot get an IUD if it's not menstruating. Lots of rules that are really not founded in research. And we have to produce, from Berkeley, we produce information to governments and program planners to really release those unnecessary rules. Rules such as, for example, the community health workers cannot dispense contraceptives in places such as in the Sahel, where women have limited mobility, for example, to go outside the house. We need those community-based distributors because they come and visit in the house, and they can talk directly about family size, and they can mention contraceptives, and the women can make the decision to space their pregnancies and achieve the desired family size. Pills of prescription are a big problem. Most of you have traveled to Africa and you know that you can get into a pharmacy and buy. Yeah, that's in an urban area. When the asphalt ends, there are no more pharmacies. So there are shops sometimes, right? And if the pills are on prescription, this gentleman cannot sell it. So women that only go to him to get their medications will not be able to get the pills. So those are the legal barriers that we are talking about. The other important part about the community health workers that we did some groundwork here at Berkeley is that we trained community health workers, lay healthcare workers in the community to give injectable contraceptives. Injectable contraceptives is the fastest growing method in sub-Saharan Africa, but there are a lot of restrictions, especially for rural women, a lot of restrictions about who can provide because it's an injectable. And we were able to demonstrate, and with our work and the work of some partners, the World Health Organization was able to then put together the information and tell countries that it's important to increase access to injectable contraceptives at community level. So some other problems that we can see, or challenges related to cultural and sort of a religious opposition to family planning, yes, they do exist. But the reality is that every country that has achieved low fertility or have high contraceptive prevalence has dealt with the problems. And we know now today how to deal with it. And this is a priest in rural Ethiopia that has written in the back, this is a workshop about family planning, and he has written in Tigrinya the barriers to contraceptive use of women in his village. He knows what the problems. He didn't read our papers. didn't know that we were researchers and spent most of our life looking at those problems. He knew right there what the problems were, and he volunteered, became one of the community-based distributors of injectable contraceptives in Ethiopia. So this is just an example of how we can deal with things, and it's very important. So in summary, increasing access to family planning is an urgent priority for low-resource settings for all of the benefits, not just health, but beyond health that family planning can bring. It is feasible and achievable, can be implemented now with the knowledge that we have. We just need more resources to make it on a very large scale, because we need to focus on the poorest of the poor, because it's among the poorest of the poor where maternal and child mortality are the highest. It is also among the poor where the average number of children is the highest. They have the highest unmet need for family planning, and they also have the lowest contraceptive use. So to ensure that this happens, it will require political commitment. It will require programmatic commitment. It will require the increasing financial and human resources for family planning, so both at the local government and from international agencies. But the good news is that we know how to do it. We can do it better, and we can achieve it faster. We have public and private partnerships that can be put in place. We don't have to rely solely on governments, but we need their financial contribution and also their buy-in. And here at Berkeley, we are really in the right place, and we have already started working in those steps and are making significant contributions. So thank you so much.
Thank you, Ndola. It's so tragic to have these short presentations, because from the experience of hearing Ndola present, she can just roll out all of these incredibly innovative approaches that they're taking, like you saw in the very last slide, all over unreachable places in rural areas, and it's working, and they've been able to, this is incredible stories. And if you'd like to hear more of those stories, please talk to Ndola during the break. Because we wanted to give you kind of a smattering of ideas and still have the networking session, we're not doing the question and answer formal period. So right now we're going to have a 10-minute break, and you can ask your questions directly to those who have presented and to the rest of the people that I pointed out also. And we're going to come back at 3:30, and then we're going to continue with our program and then have time for networking at the end. Thank you. Okay, please take your seats and quiet down. How's that? Or I'm going to learn how to do those horrible whistles. Okay. Actually, I have an ex-high school teacher in my lab, and she's amazing at getting everyone to shut up and pay attention. I'm like, you guys, and she's like, okay, so we're starting again, and this time we're going to have a slightly different format. We're going to have 4 10-minute talks, and then we're going to have a longer networking session where you all can interact. And so I'm excited to introduce Stella. I'm going to destroy her last name. Okay, Jaguna is my attempt. And she's, I mentioned that we have also programs in exchanges of faculty. And so actually, I don't think the dean mentioned this, but it turns out that the School of Public Health at Berkeley, we think, has the largest number of Fogarty International Center training grants than any other School of Public Health in the country. Ranging from tobacco to infectious diseases to mental health. And so this is the Fogarty International Center at the National Institutes of Health. It's their one arm that is dedicated to training, and universities can apply for training programs. And so one of the ones, which is directed by Dr. Art Reingold, is on AIDS. And so I think it's been there since like 25th year. And we're really excited to have our 27th year maybe. Third, okay, there you go, now I got it right. And so we're able to invite stellar professionals like Stella to be here with us, and she's actually in the process of doing her 1-year MPH, Master of Public Health and Epidemiology. And one thing I wanted to mention, which I was remiss in saying, is that you're either sitting on or in your seat, there was a white card which you can fill out and give it back at the end in order to be linked into some of our programs, which include events like today, as well as an evening seminar series that we have at the house of faculty members. And then we also have Brown Bag Lunch Series that focuses on nonprofits that are working internationally in the Bay Area. And if you'd like to be linked into that or join our donor trips or board of directors, please let us know. So now to introduce Stella. So after completing her studies at the College of Health Sciences at the University of Nairobi, in Kenya, Stella worked for several government hospitals in various districts throughout Kenya, and her main interest areas are in HIV and opportunistic infections in the rural areas of Kenya. She's also worked on the couples intervention study in Kisumu and on a discordant study, a couple study in the PrEP study. This is all related to HIV transmission in discordant couples. And so she is now one of our 2011-12 Fogarty Scholars, and her plan when she returns is to focus on implementation science and clinical research with the aim of transitioning the findings into policy. So what you're going to see over and over again is the theme of doing research that's based at Berkeley with our collaborating sites, but the aim is always to both have it service-based and into communities, and at the same time be able to use that evidence to transform policy. So there's always that move out into both the community and into policy. And that's a theme, I would say, of the work here, both at the school and at the CGPH. And so the title of her 10-minute presentation is going to be an overview of HIV research, care, and training program in Kenya. I'm happy to welcome Stella. Thank you.
Good afternoon, everyone. I am happy to present to you this topic, and maybe I should start by giving you a brief overview of how I entered into HIV. I remember when I was a third-year student at the College of Health Sciences, we had mandatory ward rounds that we had to go to. And I remember there was this ward 7 and ward 8 was just dedicated to HIV. And the moment you just step out of the elevator, you just hear people crying, women screaming because they've lost someone or they're in pain. And I knew for sure that I wanted to enter into the HIV field. So basically, I'm going to talk about the overview of KEMRI, where I work, RCTP, our program, and the ongoing researches that we have in the program, PrEP, the main study that we're going to talk about today, and of course, you can ask me any questions. RCTP is Research, Care, and Training Program. We are affiliated with the Kenya Medical Research Institute under the Center for Microbiology Research. Under the RCTP program, we are split into 3 units. We have the research arm, we have the research, the training, and the care arm. Within the care arm, we have the FACES program, which is the Family AIDS Care Education Services. We have 106,000 individuals enrolled into the program. 45 of this are actually on care. Within the care program as well, we have various ongoing operational research, but due to the interest of time, I'm unable to go through all this. The training component, we work with Fogarty here, both at the UC Berkeley as well as the University of Washington. We get students both from University of Nairobi, University of California, San Francisco, who want to get in touch with more infectious disease infections that we face in Kenya, as well as diseases like malaria. And we help them get on-the-job training to actually see it theoretically and not just what they find out in books. Within the research arm, we have all this. These are some of the ones that are going on. The PrEP study and the IPM study and the fisherman study are mainly preventative study. The HSV2 HIV study is a herpes simplex virus study, which we wanted to assess whether taking a cyclovir helps you prevent HIV acquisition in discordant couples. But I'm going to talk about that a bit later. Nairobi is our main headquarters. We have units both in Mombasa and in Kisumu, but most of my work is actually based in Kisumu because Kisumu has a prevalence rate, a prevalence of 15% as compared to the rest of the country. Most of the country has prevalence of 7%, so we can see most of our burden is based in Kisumu. Why HIV prevention? No single strategy works. Male circumcision, yes, has been shown to reduce HIV by 60%, but it's not the only, it doesn't work for everyone. What about the women who are at risk, especially women in discordant relationships? The latest survey in Kenya, the Kenya AIDS Indicator Survey, showed that among individuals who are married, 45% of their partners are HIV negative, meaning that quite a number of people are at risk of getting HIV in these relationships. Women, especially women in rural areas, as Ndola said, they cannot negotiate condom use. They cannot tell their partners that they do not want to have unprotected sex with them because of a poverty issue. They'll be kicked out of their houses. Where will they go? What will they do? How will they feed their children? So we as the medical fraternity have to find ways of helping such individuals prevent acquiring HIV. This is a mathematical model that I like presenting to people because it shows that we need a comprehensive package in order for us to be able to reduce the HIV infections that we get. Studies have shown that for every one person who is started on ART, 6 new infections develop. What is going to happen to the 6 new infections? How are we going to prevent them? We need a comprehensive response to this scourge to be able to combat HIV. This is just a depiction of where we work. HIV discordant couples basically means that one partner is infected with the HIV virus and the other one is HIV negative. We have done several studies. We have done the HSV2 HIV study, which means it was a herpes simplex virus study, where we used acyclovir to check whether daily taking of acyclovir prevented HIV acquisition within discordant couples. Unfortunately, the results were not positive, so we went back to the drawing board and PrEP was born. With PrEP, we've managed to enroll 629 couples. And within the PrEP study, we're also doing an ancillary study assessing the impact of social capital on adherence, which I'll touch base on a bit later. As I said, HIV discordant couples are the key to the answer, especially in our setting, because we've seen that most HIV infections are now occurring in stable relationships. Condom use is no longer practical on its own. Most of the couples that we have in our clinic are young couples, people who want to get pregnant. How are we going to prevent them from getting the disease? We need to come up with multiple strategies to cater for the variety of people that we have. What is PrEP? PrEP is basically taking an antiretroviral to check whether that will prevent you getting HIV. In our cases, we use tenofovir and Truvada. We did this. Can a pill help prevent HIV? This was a multi-site trial. We have 5 sites in Uganda, 4 sites in Kenya, all enrolling discordant couples. We randomize the HIV negative partners. In this case, we're using the negative. They're the ones taking the ARVs. Split them into the 3 arms, followed them up for 36 weeks. Back to the social capital and support groups. These are some of the couples that we have in our study. Basically, in our clinic, it's more of a holistic approach. We also do counseling. We want to find out how the community is accepting the HIV discordant couples. We want to find out how the community is helping their health outcomes. And this is a study I'm proud to be the PI of, and the results will be out soon. Our results. PrEP works. Both PrEP and TDF prevented HIV infections. Tenofovir reduced by 62%, Truvada by 73%. We have diverse needs for our community. not everyone, 45.8% of Kenyans live under $1 a day. How is everyone going to afford how are they going to afford the drugs? How we as a community, how are we as a fraternity that's doing this research going to help the community at large? It's all well and good that we have the study, positive results, but how are we going to implement this? My challenge is what I think will be a problem. What I think will be a problem in PrEP, drug resistance. In Kenya, and I'm sure in many African countries, we have a lot of black markets. My fear is that we'll get some inferior drug for Truvada, and this will be distributed to the country. What is going to happen to the people who have resistance? How are we going to handle that problem? How are we going to help them once they get HIV because they're taking a substandard medication? How are we going to be able to monitor the adherence in these populations once we roll out PrEP? Screenings of HIV and STDs, this has to be done on a monthly basis. Do we have the capacity to do this throughout Kenya? Sexual disinhibitions. Is it going to make the society more promiscuous because now they have a pill a day? Is PrEP going to become the new morning after pill? How are we going to target marginalized communities like the homosexuals and the prostitutes? How are we going to do that? The dosing. We don't know whether you take PrEP 24 hours prior to sex. Do you take it 2 hours after? Can you take it 2 hours before sex? Will it still work? These are still some of the questions that we need to iron out. Policy translation. Is our government ready to accept the idea of PrEP? Do we have the manpower? Do we have the logistics to handle rolling out PrEP? Sustainability. All these questions I think we all need to answer. In summary, PrEP does work, especially for high-risk communities and populations, HIV discordant couples especially. So at the end of the day, we, especially my clinic now, we are aiming to roll out PrEP once the FDA approves as a comprehensive package. And I hope you'll all join me in the fight as our mission statement goes, in search for better health. Thank you.
Wonderful. Thank you very much, Stella. It's exciting to see the work coming, as we say, not just from Berkeley out, but from outside in. And we're very happy to have you here with us and to be able to share. This is very exciting to see actually progress, not just the doom and gloom, but actually the solutions. And so it's very exciting on all different fronts. And now we have another aspect of this work. Actually, Coco Oswald is an MD, MS, and associate professor in the Division of Adolescent Medicine at UCSF and an associate professor in the School of Public Health here at UC Berkeley. She is also the director of our MS program for the UCB-UCSF Joint Medical Program, which is actually a really wonderful program where the students get an MD, but then also take a year to do a Master's of Science program. It's 3 years, actually, that focuses on actually many social determinants of health types of aspects. So they're not getting a narrow medical education, but rather one that's grounded much more in a vision of community. And so we're very happy that Coco is working on and is directing that program. She's a pediatrician and a specialist in adolescent medicine, and her research interests include the study of the contribution of culture and social factors to HIV and STD-related behaviors, especially in marginalized youth populations. As I mentioned, this is both homeless in San Francisco as well as in Kisumu, and what she's going to talk about is actually, it turns out, the same group that you just heard Stella talking about, but she's coming at it at a different angle, which is actually, she's not going to focus on her HIV, STD work per se, but rather the interaction and work with marginalized youth in Kenya. So without further ado, I'd like to introduce Coco. Thank you.
Well, I want to say asante to Stella for introducing the RCTP and KEMRI to all of you. And I'm very proud to be Rafiki Ya KEMRI, so a friend of KEMRI. So my interest in adolescent medicine, as Eva said, stems from my interest in the effect of cultural factors and social factors on adolescent health. I actually came here to be a JMP student 26 years ago now because I was interested in understanding these factors better. And in no group more than adolescents do social and cultural factors influence health? This is a picture of adolescents in Tunisia, my mother's home country. And I started work with homeless youth 15 years ago because among adolescents for marginalized youth, this is particularly the case, that social and cultural factors are the primary determinants of their health. And I started this work at a time where the literature could be summarized as what I call the bad things these bad kids do. And so there was just a litany of studies listing all the horrible behaviors that these young people did on the street. And it was a very individually focused literature, and that was what was most striking to me as a JMP grad, was that it was so decontextualized, and there wasn't really an understanding and appreciation of how the street environment and the social context of homelessness contributed to the production of risky behaviors. So funded by grants from the National Institute for the Child Health and Development and a number of other sources, I have spent about 15 years now, it's hard to believe, examining the role of street culture, social networks, and a model we derived, the life cycle of youth homelessness, on the HIV and STD risk among homeless youth in San Francisco. I was asked to come to Kenya 5 years ago to look at translating some of this work along with my colleague Elizabeth Bukusi, who invited me to come, to look at how this work could be translated to the challenges of youth homelessness in Kisumu. And we found that, it looks like a familiar picture, and we found that a lot of similar lessons apply to what we learned. However, it has been very important also to adapt these lessons to take into account both the profound poverty in the setting of Western Kenya and the effect of the HIV pandemic, which cannot be underestimated. In addition, our work has been compromised by the fact that research in this area of street children in sub-Saharan Africa is almost absent. There's a preponderance of studies that are descriptive and non-explanatory of well-meaning individuals conducting primarily qualitative work, trying to bring the case of these young people and children to light. But there is, and I really hope one of you can step up to me and tell me that I'm wrong. I've been doing literature reviews in this area for 5 years, and I haven't found a single epidemiological study looking at HIV or STDs in this population, nor have I found a single longitudinal study of any street children at all in sub-Saharan Africa, and no studies that provide any theoretical explanatory context to help us determine what points of intervention would be most critical. And despite the HIV pandemic and the focus on orphans and vulnerable children, street children are not included in HIV prevention and planning, primarily because it's a population that elicits a reaction that probably many of you have walking down Telegraph Avenue, which is just disheartenment and despair and a feeling that it's a population that can't be engaged. So this is where the Vijana Wetu project came from. Vijana Wetu means our youth. We named it for good reason, to show community ownership of these youth. And this is a beautiful logo designed by a young man who came from the streets of Kisumu. And our goals in the Vijana Wetu study were really to show feasibility. We had a tiny amount of money, we have very little time, and we also felt that the kind of longitudinal ethnographic work that I had done in San Francisco was not a luxury we could afford. And so we really wanted to show feasibility of working with this population. We wanted to show that it is possible to sample these youth in a scientific way, to recruit them for an epidemiological study or a pilot intervention study, to show that we could test them and refer them to care, to show that we could track youth over the time, and that we could do this in an ethical way that would respect their child rights. So you've had a chance to hear some about Kisumu from Stella. And Kisumu is also as Stella said, the capital of Nyanza province, and Nyanza province is the largest ethnic group in Nyanza province are the Luos, and I'll just jump ahead here. The most famous Luo in the world is, after all, our president, Barack Obama. So I have to mention that. And I remember sitting and having beers with some of my colleagues 5 years ago when they said, well, do you think he could run? Do you think he could be president? And I just thought, who knows? So it was great to see them dance on Election Day on American TV. So Kisumu has culture or an economy based on fishing, and is the ground zero really for the HIV epidemic in Kenya, which means that it also has the highest rates of orphanhood in Kenya. There are many communities in Nyanza province where 1 in 9 children actually are either single or double orphans. Imagine if that were the case here in the United States. And for adolescents, obviously, since that's an averaged out rate of orphanhood, for adolescents the rates are much, much higher. This means, of course, that there is a large population of street children. So when we decided to look at how to recruit youth, we started off by conducting community engagement work, and we started mapping where youth were spending time. And so this is a map of some of those sites. We also did work to look at how to sample youth, and we had to look at challenges to sampling youth because it's a marginalized population. We could have just done a convenience sample of kids who go to a drop-in center, but convenience samples are just that, convenience samples. It means that you're only going to get the kids who access that center. We decided we were going to use the gold standard way of recruiting marginalized populations, and that is respondent-driven sampling. So we gave out these really fun coupons to 3 youth who acted as our seeds. Each of them got 3 coupons, and then we were able to show that we were able to recruit our target population of youth in an extremely short amount of time, and that this work was feasible, acceptable, and effective, and I'm happy to share the findings of this work with you. We were also able to show that we could test all these youth for multiple STIs and HIV. We were able to notify all positives of their results and refer them all to care. Mind you, these are all children who are based on the street and who we recruited from the street. We were able to retain 70% 2 months later, 70% of the youth 2 months later, and we had reliable data about the location of another 15%, but for lack of resources, we could not do any tracking outside of Kisumu. We developed a model for the life cycle of youth homelessness in Kisumu, which I don't have the luxury of describing to you today, but I will share a couple quotes sharing their experience. One young man talked about the family factors that led to him being on the street. What made me come to Kisumu was when my mother died, my dad married a stepmother. When he married a stepmother, she used to mistreat me. She would chase me from home, refuse to give me food, so I decided to come and live on the street. Orphanhood as a result of HIV and remarriage or having children, having to go to extended family for care and lack of resources to take care of those children is a significant factor leading to children being on the street. Once on the street, stigma is an important factor that affects their health. Well, I would say life on the street is different. One night I was sleeping at night and there were a blackout and the police rounded us up and we were sleeping inside like a dustbin, a big one. So they came and rounded us, started beating us, kicking us, and we were told to strip our clothes naked, and we were really thoroughly beaten that day, I know. I will never forget that day. Police abuse of street children takes place worldwide. It takes place across the Bay and here in Berkeley, but is a very important factor in understanding youth health, and the stigma that affect these children and that prevent us from protecting them is an important factor that we need to address. And I would just want to point out this is a child picture describing a police is beating me, and he's wearing his Obama shirt. So Vijana Wetu was a very small study, but it was the first to recruit a systematic sample of youth in sub-Saharan Africa for an epidemiological study, for a study that was able to test them for HIV or STDs, and to follow this cohort longitudinally, even though it was for a short period of time. And the first study that we know of that suggests some points of intervention. So just quickly, in terms of what's next, we know that these young people can be productively engaged, but we also know from our work that the determinants of their health status are not individually based, and that no amount of outreach and education is going to change the stigma and the loss of social ties that these children experience. We already talked some about the role of social capital from Stella's work, and we're very interested in looking at multi-level interventions for social capital to change these children's lives, because the fact that they have lost familial, community, and social ties and any value or ownership in their community is really the primary determinant of their ability to be productive members of their society in the future. So we're looking at having youth share their stories, possibly through photo voice, a method where you give marginalized populations cameras to document their lived experience. This type of work can and has been shown to change attitudes and policy, and we think it will be very effective in Kisumu. We also want to work with existing curricula with the police to decrease violence towards these children. Through a change in attitudes and destigmatization, we're hoping that we can also have children be brought back to their families, possibly through microeconomic interventions with families. This is one example of microeconomic intervention that takes place in Kemri. It's a pump to enable subsistence farmers to become merchants. And so these pumps given to families of street children may enable those families to reintegrate those children. And so right now we're doing a pilot study to talk instead of youth, to talk to communities about what types of structural interventions we could engage in to reintegrate them into their homes. I want to thank our collaborators and our funders, and thank you very much for your time today.
Thank you so much. It's so wonderful to see solutions. And thank you for doing this. Thank you very much, Coco. And I'm sure you'll have questions for her during our networking session. I would like to introduce next Professor Nap Hosang, who is a lecturer in the MCH, the Maternal Child Health Program, and chair of our interdisciplinary MPH program here, which is a one-year program for essentially students, if you wish, but people coming back from the professions and then wanting to do a master's, an MPH, and NAP manages to arrange all of their diverse interests in a single year and produce a wonderful cadre of graduates. He is also a practicing obstetrician at Kaiser Permanente and received his medical degree initially in the University of West Indies in Kingston, Jamaica, and his MPH and MBA here at UC Berkeley. He works on a number of aspects in management of maternal and child health services in developing countries being one. His teaching emphasizes leadership development and management training in public health education. And what he's also done is with Martha Campbell has established the Berkeley Center for Entrepreneurship and International Health and Development, which is facilitating entrepreneurial ventures to improve the flow of reproductive health commodities to rural areas, but also the supply of improved cooking and heating stoves. And this links back to the work of Professor Kirk Smith, who I mentioned, and the work in Guatemala that will be our first donor trip. And what they've done here is to be able to roll this out in Uganda, now not through an academic system, but rather in the entrepreneurial sector and nonprofit world. And what he's going to do is give us an example of how this has been working in Uganda. Thank you, Nap.
Thank you very much. So let me explain. The brochure you have has a picture that's on the bottom, and that's what I'm going to talk about. Those orange things, and they're stoves. Let me tell you how I'm going to spend the next 8 minutes or so. I'm going to tell you about a pretty stove and how it saves trees and lives, and what the byproducts of these are with respect to lower fuel costs to communities. The key word today is poverty, and so the question is, in this context of Africa that we're talking about, how can we have an impact on poverty in a measurable way that's sustainable over time that doesn't require continuing donor dollars from abroad? The other part of the talk today is really about an exercise in translation. How do you take knowledge that is appropriately acquired through research in a university center like ours, and I'll mention that in a minute, adapted for a real environment, the practical exposure of being in a place somewhere that has context, and then do something with that information that actually makes a difference in people's lives. So how do you do this? Press one button? Yeah. So our main aim, you can see I'm an old-fashioned guy. Our main aim is to improve living conditions and local environments for the most marginalized populations in the world. I'm just going to speak about stoves and Uganda today, and to ensure that the benefits of carbon finance reach those in greatest need. In Uganda, 95% of the population relies on biomass for cooking. Biomass is crop residues, wood, cow dung, you name it, anything that has some unspent carbon in it. Over 31% of the population lives on less than $1.25 a day. And the poorest families spend around 15 to 20% of their income on fuel, which can sometimes be as much as 1,000 shillings, Ugandan shillings per day. And on the health side, women and children spend as much as 6 hours, maybe sometimes 8 hours a day involved in cooking activities. And because they have to have their 2-year-old children and younger around them, those children actually get exposed to the same kitchen environments that they're in. Now, the company that we have formed, this is an offshoot of the center that we created, Martha and I created in Berkeley some 10 years ago. We spun this organization off outside, and it's called Impact Carbon. But the approach of Impact Carbon is, as you can see here, you can read it yourself, but basically we tap into the power of a carbon market that became available to us about 6 years ago, and use that component to get to marginalized populations because they participate in the process. And we make sure that we have an arrangement that the revenues that we earn are actually passed back to the same community. So we're not victimizing the population that's helping to earn the money by then taking the profits away. So that's an ethical stand that we take. And it's market-based and community-based too, in that we actually go back to the end users and ask them, how have we done, and have we done you any good? So far, Impact Carbon has sold more than 100,000 charcoal stoves to families. That's about 3% market penetration where we are. Our target is 10 million, so we are about 100 times, we've got 100-fold to go. So this is not over. If you're going to have in public health any kind of population effect, it has to affect a large number of people, and 100,000 is just a spit in the wind. And of course, children go to school, so you might want to use these cleaner burning, energy efficient stoves in institutions, schools and hospitals where available. And we've calculated that about $75 US dollars per year is saved per family on the amount of money that you spend on fuel. Now, that may be higher in some areas and lower in other areas, but on average about 75. And that's a real impact on disposable dollars in the family, because you heard Ndola say, if you don't have money to put food on the table, you're not going to buy a birth control pill. So similarly, you can think that more money that's made available disposable will mean that there are impacts elsewhere in the family. This year, we have accumulated about 250,000 tons of carbon saved from stoves that have been sold in Uganda. And then we converted that to dollars, and we have a contract with the Europeans because the Americans are not yet on board. Well, it's not a bad idea. You're getting European money to fund stuff in Africa, and we're the middle people, so it's good entrepreneurship. But you can do the math in your head about how many dollars that is. So it gives us the capability to keep doing what we're doing, so we don't actually have to go to donors and then ask for more money. I'm going to tell you how we go to donors and why we go to donors, but there's a context for that. And we save some trees as well. But Okay, so the Uganda project, just a brief history. We started out with Kirk Smith's research, which is pretty solid research, published in appropriately peer-reviewed journals. Then we collaborated with the PCIA, which is a US-based organization. Well, it's an international-based organization for looking at ways in which we can improve the quality of burn in the design of a new kiln. We worked on these design improvements in the various laboratories around the country, Denver, here, even experimented in China. But in effect, we are able to build a better burning machine. Then a bunch of graduate students went on and did initial monitoring and evaluation work to verify what the expectations were of the new technology. At that point, we were still begging and asking for money for people. And then about 6 years ago, it became possible for us to measure the amount of savings in fuel there were from these stoves and to translate those into earnings in carbon benefit or carbon offsets. And we actually were able to do that through the work of a graduate student here who made the first effort to explain how that methodology could be done, and it worked. So we got our first project registered in 2007, and our first verified credits, which were bought by Land Rover, ironically, in 2010. We just received our last one about a month ago. Okay, so how is carbon credits, or how are carbon credits made? It's a very complicated system, but basically partners earn by joining with us the carbon savings, which we then convert into credits that we get to sell on the market, and in the end, we collect the revenues. The organization now will have, or has the ability to provide consulting services and training capability. And locally, we help local organizations that are building stoves to build a better stove. We are able to help assist them in the social marketing, to develop their distribution channels, monitoring and evaluation for quality, because without quality, we don't have a product. And we are on the constant lookout for partners who are willing to submit to these rules or guidelines for being a credible partner with us. And if they are, then we can build projects upon which we can expand the number of stores being built and sold. So here's a little bit on monitoring and evaluation. I don't want to spend much time on that, but you can't just sell a stove. You need to actually measure to make sure it's being used and that it doesn't deteriorate. Obviously, as you're building markets, there is development that comes with that and brings jobs. And we have to have a system in place that we can use to make sure that the new technology is adopted. The most common reason why folks buy these stoves is because of the color. The health benefit, we don't advertise, and the fuel benefit, we don't advertise because word of mouth goes around where people actually hear about the savings. So I'll just read you one quick quote from one of our users. The Yuga stove product is so great that if I had the money, I would buy them for all my friends. It saves me 1,000 shillings per day on charcoal compared to my other stove. So where is the opportunity for support here? It's clearly in the area of scale, because 100,000 stoves is really not enough to make a difference. We're thinking 10 million, and the startup costs related to this are formidable. We can guarantee a return on your investment in 2.5 years, and it would effectively create the opportunity for a revolving loan fund. So in effect, we could actually pay back from the earnings of the carbon for the upfront investment. We do have needs in the area of marketing distribution, and we do have needs in the area of making it accessible. In other words, some sorts of subsidies or credit rating and price. So with that, thank you very much.
Wonderful. Thank you, Nap. So I knew there was a reason I should understand business at some point in my life, and now is that time. So that was wonderful. Thank you. This is such a great opportunity for me because these are all my colleagues that I never know quite what it is they're doing, especially since my work focuses in Latin America for the most part. And this is a wonderful day for me in particular. So thank you all for making that possible, Jeff in particular. No, so what we're going to do now is to deviate a little bit from our program because Laura Stachel has been able to join us. She was initially on the program and then was unable to come, and then at the last second was able to rearrange her schedule. So we're so happy. And she's going to talk about another project which is really translational. And so her background, she's the associate director of the West African Emergency Obstetric Research for the Bixby Center. And she's a board-certified obstetrician gynecologist with 14 years of clinical practice. Now, she left private practice to pursue public health studies at Berkeley in 2003, received her MPH in maternal and child health here in 2006, and is currently pursuing her DRPH, her doctorate of public health. She is the co-founder of We Care Solar, which is a nonprofit dedicated to saving the lives of women and infants by enhancing emergency obstetric care through the use of solar-powered lighting, communication, and emergency equipment. And she also serves on the editorial board for Berkeley Wellness Letter and is a lecturer at the School of Public Health here. And so we're really happy to hear your story. Thank you.
Well, I just want to say a couple things first, which is one, I've just been so impressed by all the speakers here, and I'm just honored to get to even share the podium. And second, that there's really a lot of people in this room who have been collaborators, supporters, and that this project never would have actually occurred without the support of many of you. So much appreciation here. I want you just for a moment to imagine that you're one of the 15 million women who develop a pregnancy complication this year. You're poor, you're trying to give birth by yourself in a small room, and it's been 2 days, you still haven't given birth, and you know something's wrong. Your family struggles to pull together the resources to bring you to a health facility where you arrive late at night. A midwife ushers you through the door, tries to understand why you're bleeding so heavily, tries to find out if your baby's still alive, and tries to locate a doctor who can perform the surgery to save your life. And this is the only light available. This is the grim reality for so many women around the world, and it's part of the reason that women in northern Nigeria, where I do most of my work, face a 1 in 13 chance of dying in childbirth, not from rare conditions, but from conditions I've treated for years as an obstetrician in this country, yet never associated with death. Part of the reason for this high rate of mortality are the factors that we've heard so much about today: poverty, illiteracy, lack of access to family planning, lack of access to skilled care. Most of these women actually attempt to deliver at home. But part of the reason actually lies in the health facilities themselves. 3 years ago, I was invited by the Bixby Center to join a collaborative research project with Ahmadu Bello University in northern Nigeria. Some of the formative research by the Bixby Center suggested that women were actually being turned away from health facilities when they came to seek emergency care, or that they arrived in health facilities and waited hours, if not days, to try and receive care, and many of those women died. So I was actually invited to do a participant observation study inside the health facility. I was asked by Daniel Perlman, who's in this room. And I spent 2 weeks just observing what was happening in the hospital, spending up to 10 hours a day just watching my colleagues, nurses, midwives, and physicians. Some of the conditions are depicted in the next few pictures. This is a photo of labor and delivery. None of the equipment, lighting, and some of the things that we just associate with labor and delivery in this country. If you turn around from where that last photo was, you'd see this is the area where there's water, and don't look at the sink. It's actually the bucket because there was no running water in the hospital. The operating room tried to exist without reliable electricity so that the light over the table was almost never used. In fact, it was the ambient light from the windows that was necessary to perform life-saving surgeries. And without a source of reliable electricity in northern Nigeria and many other places in the world, blood transfusions are very hard to achieve. So a woman like this who came in needing many units of blood had to wait more than a day for family members to be solicited, tested, and checked to see whether they were compatible blood donors, because there was no way to store blood in a refrigerator. Another issue that was striking was that there was no reliable source of communication for an emergency team to assemble when surgery was needed. So, for example, when a woman came in with placenta previa bleeding, a condition that in this country would result in a C-section probably within minutes, it was 4 hours before a doctor could be located and required a messenger to physically run around the hospital and then around the grounds. And it was only when I started banging on the door of other doctors I knew that we actually got a team. But it was too late, and this woman lost her baby. And I saw countless examples like that. And at nighttime, when grid electricity was down, this is the only light that was available. This is actually the nursing desk in a maternity ward, and if you could flip on the lights, you would see dozens of people that are actually in the room behind her, mothers with babies and family members who come in and literally sleep on the floor at night, but during the day provide care for the patients who are being hospitalized. So that was a quick introduction to what I saw in 2008. And even though I went there as a physician thinking that maybe my clinical skills could be helpful, I felt that there was a profound problem that needed to be addressed first, and that was the issue of electricity. I have the good fortune of being married to someone who teaches solar electricity, and when I sent him letters from Nigeria, he said, I think we could come up with a solution to help your hospital. And that was to use a free source of fuel, the sun, to provide solar electricity to this hospital. I should mention that there are many, many issues that we identified during that first couple of weeks of observation, and that clearly we are only focusing on one small portion, and I don't want to imply that taking care of electricity is going to fix a medical system that has many, many problems, but I do think it's a very important component. So my husband designed several solar electric systems targeting 4 areas of the hospital that we thought could impact maternal death: the maternity ward, the labor room, the operating room, and also the laboratory, because we wanted to supply power for a blood bank refrigerator. Before implementing this project, which was actually funded by the Blum Center at Berkeley, I asked my husband if we could put together a small prototype, a demonstration kit that I could bring to my colleagues in Nigeria to see whether they would actually like the idea of solar power and whether they would like to use some of the high efficiency items that we wanted to implement, such as LED lights and also walkie-talkies to try and facilitate communication. And I said, I need something small enough that we could actually fit it in my suitcase so I could get through customs easily. And this is a picture of me unpacking that first solar suitcase. Well, not only did they like the kit, they said, could you please leave it in place? And I said, well, this is actually just a demonstration. But they convinced me to leave the equipment over the next several months, the equipment was used to charge batteries for headlamps that I had brought, to charge walkie-talkies so that we could quickly assemble an emergency team when a C-section was needed, and even to power overhead lighting. And when we were able to put together the larger project in early 2009, we were able to bring large solar panels, and the maternity ward went from looking like this to this, and an operating room went from looking like this at night to this. And what I want to bring your attention to is that this particular photo is using LED lights that are only requiring 15 watts of power. And so all of a sudden we realized that maybe we didn't need to get a huge system of solar electricity to make a difference, that maybe if it only took a few watts of power to make a difference and allow an operating room to function at night, maybe we could do something else and bring it to scale. I should also mention that there was a blood bank refrigerator that we installed in the laboratory. And over the next year, in following the rates of maternal mortality within that hospital, they went down by over 50%. And the capacity to see patients increased because nurses no longer were turning people away from the doors at night, because now they could assemble an operating team and they could admit patients and actually do deliveries with adequate light. Honestly, I thought the journey was going to end at that point, but some of the friends I had in Nigeria started bringing me to clinics around the hospital, and soon we were being asked to bring solar power to many facilities. And that got us to think that maybe that small demonstration kit that we had used in early 2008 could actually be changed into a purposeful kit, a solar suitcase. And that's indeed what we did. We took a lot of the components of that large system, we shrunk them down to the size of a suitcase and brought portable solar panels and a small battery so that we could power LED lights for childbirth or surgeries, power cell phones or walkie-talkies, and power rechargeable batteries to be used for medical devices and headlamps. And with greater expansion, these same systems could be used to actually power things like laptop computers on larger devices. So here's just a couple of photos showing some of these neighborhood clinics that received the early solar suitcases, which included the Millennial Village Project Clinic in Pampeta, and then a subsequent one in another village. At that point, I thought maybe we were done, but we had some other interest internationally. We started getting requests literally from all over the world after having some publicity from the New York Times. And soon we were being asked to send our solar suitcases to places we had never been. And some of you in the room are actually couriers who have been couriers for the solar suitcase. So in Rwanda, we sent a suitcase with Wendy, who's in the room, and Catapult Design, who brought the first electricity to a small village clinic in Rwanda. And Gloria Upchurch, who's here, brought a solar suitcase both to a primary school and to 3 clinics and hopes to bring more in the coming year. We've had other suitcases brought to Tanzania. And most recently, we were asked to partner with the World Health Organization in March, and we brought 20 solar suitcases to rural health clinics as part of a study they're doing looking at the impact of electricity on maternal survival. So where are we at now? As was mentioned by Ava, we started a nonprofit organization. A lot of the work that we're doing is trying to make the best product possible, going into health facilities, understanding what user needs are, and trying to make a product that's responsive to that and that can withstand a lot of the harsh environmental conditions in which many of the clinics we work are located. We're also partnering with institutions like World Health Organization, government institutions, ministries of health, and we're looking for partners even from this room who can be people that can actually deliver the suitcases to where they need to go. But in addition, we're interested in building capacity, and we're doing trainings so that we're teaching some of the healthcare workers both about solar power, but also how do you enhance healthcare itself. So for example, in Liberia, we actually taught 60 healthcare workers and technicians about solar electricity, how do they use these equipment, and then how do you repair them if there's a problem. And we're also going to be doing trainings to teach some of the midwives in a project we're now doing in Nigeria how to use a fetal Doppler, which is a monitor to listen to baby's heartbeat to improve care. And finally, the last branch of our organization is working on doing research, such as the research I mentioned that's being done in Liberia, and a current research project that we're doing in Nigeria. I just returned from Nigeria, where I actually looked at 28 health facilities, trying to understand what are the needs of those health facilities, and how can we target our solar suitcase to really help them out. There are so many partners and people that I would love to be able to thank, and we have such a short amount of time, but I will mention MacArthur Foundation has provided funding for the current research we're doing in Nigeria. The Blum Center has provided support, the Bixby Center, and many individuals who have given generously of themselves, both in helping us do work as well as in monetary support for our project. We have a website as well as a Facebook page, and I actually brought a solar suitcase with us, so in the break, if anyone wants to see how it works, I'm happy to show you. Thank you.
Wow, Laura, I'm really glad you were able to move that schedule of yours around. So we're a little running out of time, and I am very happy to delete my concluding remarks, because pretty much I have nothing left to say after this incredible series of wonderful, wonderful presentations. And what I just want to do is let you all have the time to interact directly. I'm sure you have a lot of questions, and are hopefully as inspired and enthusiastic as I am after hearing this. And so thank you very, very much for coming. Again, if you'd like to remain in connection with us, and certainly with C4A, please fill out those cards. Let us know Miriam Rafiq is our queen mother. And thank you so much for the presenters for this really inspiring afternoon. And really nice to meet all of you. Thanks for coming.